Thank you. Hopefully everyone can see my screen. I'm really glad to be sharing this morning with you. And a very nice introduction. It just makes me kind of feel old, seeing how busy I've been over time. So this morning I'm going to talk about liver disease and reproductive health with a little bit of an emphasis on the fact that we have two guidelines, multiple resources, but two recent guidelines, the European guidelines and the AASLD guidelines from 2023 and 2021, respectively. The agenda is predominantly to discuss liver diseases that are unique to pregnancy, but I will talk a little bit about chronic liver diseases that can impact pregnancy. These are my disclosures, none of which are particularly that relevant. And then this is just a reminder of those two guidance documents or guideline documents, with the most important statement that liver diseases unique to pregnancy have to be distinguished from the first presentation of a chronic liver disease or acute liver conditions that are coincidental but not specific to pregnancy. Or in other words, the very fussy way of saying that we always worry about pregnancy-induced liver disease, but it could actually be something else. Reproductive health is also really important to understand. Even though women with advanced liver disease, or ALD, not alcohol-related liver disease, but advanced liver disease, have altered estrogen metabolism because of disruption of the hypothalamic pituitary axis, and that will frequently lead to anovulation, amenorrhea, and infertility. This increases with the degree of advanced liver disease. So if you look at just all individuals, all women with ALD, it's only about a quarter. Whereas if you look at women waiting for liver transplantation, about 75% will be amenorrheic. That means that pregnancies, even in those with decompensated liver disease, can still occur. And contraception is really important in a woman with cirrhosis if they want to avoid pregnancy. And in a person who's got well-compensated cirrhosis, estrogen metabolism is actually normal, and so they may not have any issues with reproduction as someone who has more advanced disease. Men also have some degree of, reproductive impact, often suffering from erectile dysfunction, oligospermia, testicular atrophy, and feminization. And so even if you have a man, this can sometimes also impact reproductive, decisions. So next, let's talk a little bit about evaluation of liver disease in pregnancy. So it's important, and many of you have seen slides like this, that there are normal physiologic changes in pregnancy that change over each trimester. It's really important, though, to recognize the ALT, AST, GGT, bilirubin. These are all going to be the same, irrespective of trimester of pregnancy or pregnancy versus non-pregnant. Alkaline phosphatase increases because of placental production, and then albumin will decrease, especially as the woman gains or holds onto more water. It's dilutional, and AFP obviously is going to increase. So although we will talk about the importance of looking for liver cancers and HCC screening in women with advanced disease that are pregnant, AFP is no longer going to be a valid way of looking for that. And so any abnormality in transaminases or bilirubin require further evaluation because these are generally the first clues of a woman who has liver disease during pregnancy. Now, this is from AASLD. It's just an algorithm telling you how to manage that. And the most important thing is it looks very similar to evaluation of a woman who is not pregnant. So if it's cholestatic, you're going to do imaging here, ultrasound with Doppler. And if that's negative, you're going to do additional testing to exclude common things like primary biliary cholangitis. If it's hepatocellular, you're going to look for all those common things like DILI, viral hepatitis, autoimmune disease, and it gives you the differential. And then in the middle, it reminds us that we have to put this into the context of the pregnancy itself, usually in the context of trimesters. And there's the most common pregnancy-induced liver diseases, knowing that these also do change at the time of pregnancy. And so when we talk about the importance of layering on the trimester, you can see that chronic viral hepatitis and acute diseases can really occur at any time. That would make sense. But hyperemesis is something that typically is occurring early. And so if you have a woman who's very early in pregnancy and has increased liver enzymes, you're not going to go right to acute fatty liver pregnancy because that tends to occur in the third trimester and sometimes postpartum. Whereas hyperemesis occurs early, intrahepatic cholestasis and preeclampsia HELP spectrum occurs more in the second and third trimesters. So turning to liver diseases that are unique to pregnancy, intrahepatic cholestasis is the most common liver disease of pregnancy. So it's really important to be able to recognize that, to feel comfortable with diagnosis and management. Pruritus precedes jaundice. So if your woman is presenting with jaundice, this is not going to be the first thing that pops into your head. And 80% of them do occur after 30 weeks of gestation, which is helpful because we have delivery decisions to make around that time. And it's really nice to know that you have viability of the infant. And we know that most of the risk factors are going to be related to genetics and sometimes fertility treatment, as well as hepatitis C, but multiple pregnancies do also increase the risk of intrahepatic cholestasis of pregnancy. ALT and AST can be strikingly elevated, sometimes into the thousands, but they do not have an association with outcome. So they're scary looking, but they're not going to really play that same role on outcome as other things such as your bile acids. Now, when we talk about diagnosis, bile acids are the diagnostic test. Anything greater than 10 is consistent with intrahepatic cholestasis of pregnancy, but we really don't start to see outcome issues until they are greater than 40 and usually for over 100. Now, this is a study looking at the impact of fasting as well as the level of bile acids during pregnancy. So it's a little bit of a busy slide, but it's important to know that if you are not fasting, your bile acid is going to be higher. So fasting levels can sometimes miss the high significant levels, which is important because it's really the peak that's associated with outcome and not the trough. And so you always want to make sure you're drawing those in a non-fasting state. We do recognize, sorry, I'm on timer there. We do recognize that there are some fat diurnal variation, but the most important thing is really the non-fasting state. And you want to use that non-fasting state because it's really the levels that are greater than 100 that start to increase the risk of stillbirth. And you do not want to miss that because sometimes fasting levels can be quite low in a woman who has strikingly elevated bile acids. So management, there are multiple levels of management. The first is that the mother is going to be very inconvenienced, but she's actually typically going to do quite well. So maternal complications are minimal. It's really the fetal risk that's high, and that's really the highest when the bile acids are greater than 100. So that just automatically, for the most part, triggers delivery. We also know that because of that, you're going to start testing those bile acids weekly after 32 weeks. And we will typically give ursodeoxycholic acid in a weight-based way if the bile acids look like they're going to start to increase. So anything that's getting close to that 40 level, you're going to give ursodeoxycholic acid. Urso does not always impact pruritus. And so although we do use that and hope that it impacts pruritus, for the most part, if the pruritus is not responding to urso, you're going to use antihistamines, cholestyramine, and then rifampin is unique. If you're not getting that bile acid reduction to the place that you would like, about a third of urso non-responders will also have a further reduction in the bile acids with rifampin, but it will also decrease itching in most of these women. And then there are some, issues on SAMe. There was a Cochrane database analysis that said SAMe wasn't useful, but some people will still use it in women who are particularly itchy. We used to say that delivery needed to occur at 37 weeks, so after 36, but before 38. Now that is a little bit more controversial because it's now recognized that bile acid level can be a little more, liberal. And this is our AASLD guideline, which the most important thing is to follow down on this side here, but emphasizing that you're going to initially assess in a woman who's got pruritus, your bile acids, your liver enzymes, and then these two groups here really are talking about individuals that don't meet those requirements of the lab testing that's consistent with intrahepatic cholestasis of pregnancy. It's really when the bile acids are raised and the ALT and the AST are raised. You can see here, it's not bilirubin, it's ALT and AST, that you make sure you've not missed anything. Always do imaging to make sure that you are not missing obstruction, and then manage this based on how high your bile acids are. And you can see, because the European guideline is a little newer than the AASLD one, that most of this trigger is when those bile acids are greater than 100. And they also recommend, pushing out delivery until all the way up to 40 weeks if the bile acids are not going to be at high risk. So a little bit of a paradigm shift there. Now, this is looking at a meta-analysis on how useful ursodeoxycholic acid is. And so this looked at nearly 7,000 women with intrahepatic cholestasis of pregnancy. Remember, I did say this was the most common pregnancy-induced liver disease. And they, originally there were rumors that ursodeoxycholic acid did not work, and the Cochrane database did come out against urso, but there were publications that occurred after that, and this is one of them, demonstrating that it doesn't impact stillbirth because ursodeoxycholic acid doesn't really reduce the bile acid levels in a woman who's got bile acid levels greater than 100. It's really most impactful between the 40 and 100. And so that stillbirth issue was not significantly impacted by ursodeoxycholic acid, but preterm birth was. And so just knowing that you cannot salvage something that's really scary, that has to go to delivery, but you can definitely help maintain the pregnancy by using ursodeoxycholic acid. This is a very provocative study looking at using an IBAT inhibitor. Remember, these are going to strongly decrease your bile acids. And this, in just 4 women, was an abstract at AASLD that demonstrated that you could decrease bile acid levels with volixibat, which is an IBAT inhibitor. This is, again, not on label, and these women were being treated for pruritus, not to maintain their pregnancies, but it did have a favorable impact on bile acids, and maybe that's something that could be considered in a woman who's got significant risk for bile acid elevation. All right, genetic testing is another thing that's often a conversation. There are multiple defined phenotypes. However, these are often rare when you're looking for them. So some studies say 25%, usually it's about 10 to 15%. So you're even in a population that's enriched, very high bile acid, strong family history. We typically do not see these phenotypes, which are in that adenosine triphosphate binding cassette subfamily for the most part, which has to do with bile acid exportation. But you want to consider testing still if the total bile acids were significantly elevated, if there was recurrent or early onset ICP, and then we often will do it if there's a very strong family history. Postpartum, you want to make sure that you've demonstrated resolution of your liver test abnormalities because there is an association with hepatitis C as well as primary biliary cholangitis, and you can recur. So you just want to make sure that you are not going to give progesterone based contraception, and you're going to wait, make sure that there was resolution. And you can talk a little bit about the risk of liver disease, although that is relatively small. All right, we're going to turn now to what is becoming a spectrum disease. So this is preeclampsia and HELP. We used to think of these as kind of distinct buckets, but now we know that pre-E and HELP are probably on the same spectrum. So preeclampsia is the leading cause of maternal and perinatal morbidity and mortality. So although not nearly as common as intrahepatic cholestasis of pregnancy, they are unfortunately more, have higher morbidity and mortality. The European guideline here is also much more comprehensive. So you're looking for a resource, you want to go to the EASL guideline because the AASLD guideline just has a handful of statements, whereas EASL has about 7 pages on preeclampsia and HELP spectrum. The ISSHP does define hypertensive disorders as a systolic blood pressure greater than or equal to 140 or diastolic greater than or equal to 90, with the addition of either proteinuria or other maternal end organ dysfunction, which could be neurologic, pulmonary, hematologic, renal, or liver. And so here, when you're seeing your ALT or AST abnormalities, you're really pulling in now that preeclampsia. You also could have uteroplacental dysfunction, which is things like abruption, or abnormal ultrasonography. And so you want to make sure that you're looking comprehensively at your woman with concerns for hypertensive disorders of pregnancy. Here, ALT, AST, and LDH do predict adverse maternal outcomes. So unlike intrahepatic cholestasis, where they seem to be scary but not impactful, here you really want to follow these carefully because they are associated with outcome. And you want to watch your bilirubin, your INR, because hepatic dysfunction is going to lead to the most severe outcomes. There are multiple prognostics, metrics, and the full PIRS, which stands for the Preeclampsia Integrated Estimate of Risk, is actually one of the most commonly utilized. It is not the only one. There are multiple of them, but the full PIRS or a modified full PIRS is probably what you're going to see most in the literature. And this uses pretty readily available information like your gestational age, if you're having end organ manifestations such as shortness of breath or chest pain, looking at oxygen saturation, platelet count, pull in that help impact creatinine, AST, and ALT. It's also, and I gave you the link there. It's also really important, again, a little bit of a paradigm shift in that platelet transfusions are recommended if the platelets are less than 100. So it's, even though we don't think that there's a significant risk of bleeding until they get to bleed below 60, there have been abnormalities in these individuals who've had mildly low platelets. So in the Mississippi classification, things that are definitely on the lower end have been now linked to poor outcome, and so platelet transfusion is recommended. It's important to note that the studies do not demonstrate that a platelet transfusion decreases risk, but because that risk is there, they recommend transfusion. Now, turning to HELP. HELP is, defined by the name. It's hemolysis, elevated liver enzymes, and low platelets. And you can see from our graphic here that there is significant overlap with preeclampsia. The maternal mortality is quite low, but in cases of preeclampsia where that maternal mortality is much higher, about 80% of them that have poor outcome will also have HELP. And so it really is prognostic, even if by itself it is not quite as impactful. Unfortunately, in the US, we're seeing significant increases in pre-E and HELP, up to 25% between 1987 and 2004. And part of that might be those risk factors, such as advanced maternal age, obesity, diabetes, pre-existing hypertension, which all seem to increase the risk of preeclampsia. Perinatal mortality is up to a third. So although in very mild Mississippi classification, HELP seems to be minimally impactful, in those women that have preeclampsia and HELP together, it's really starting to show a significant morbidity mortality signal. So you don't want to dismiss these women that are presenting with low platelets. Like I said, the European guidelines were quite comprehensive, and these are from the EASL guidelines, which really kind of walk you through a story. If you have a woman who's got hypertension, you want to make sure, number one, that you control the hypertension. After controlling the hypertension, which is a little bit different if it's mild versus moderate, you're going to start to be preventative for things that are going to increase morbidity and mortality. And so here there is strong consensus to give neuroprotective agents so you don't go to eclampsia, which is the seizures. You want to think about lung maturity, but you don't want to give corticosteroids unless you really think there's a risk of delivery. Here they recommend that they want to use dexamethasone or betamethasone in individuals who are having complications such as HELP, because here you're going to know that you're going to deliver that woman a little bit earlier. And you want to make sure that you recognize that prompt delivery is going to be the therapy of choice. You want to do what you can to maintain that pregnancy, but if it looks like this pregnancy is going to have increased risk, delivery is absolutely the next direction that you go. And if there is synthetic dysfunction or any kind of risk, you're going to try to move that woman to a place where transplantation could be considered. And although I did not include it here, it's really important to know that every one of our guidelines talks about how complications of pregnancy are a multidisciplinary event, so that you want to make sure you have high risk maternal medicine involved, get your pediatrician involved very early, hepatology involved very early, transplant involved very early. And make sure that you know that the hepatic complications of pre-E and HELP are often rupture, hematomas, and these are going to increase significantly if the platelets are less than 20, which starts to bring in those recommendations. Is why they recommend transfusions. All right. We are also now more preventative. So I know that Ray Kim is starting to talk quite a bit about preventative hepatology. I don't know that that has quite the same terminology when we're talking about pregnancy, but if you have a woman who has risk of preeclampsia, ACOG, which is the American Academy of Obstetrics and Gastroenterology, obstetrics and gynecology, gastroenterology, is now recommending low dose aspirin. Now, there are a little bit of difference between ACOG and EASL recommendations, but it's important for us to see that the women that are at risk for preeclampsia include not just women who have pre-existing hypertension, but also those that have chronic renal disease, autoimmune diseases, diabetes, and chronic hypertension. And so our women that go into pregnancy with MAFLD or MASLD, as well as autoimmune diseases, really should be having a discussion on low dose aspirin initiated around 16 weeks or optimally before 16 weeks. Now, ACOG recommends continuing this until delivery, whereas the European guidelines recommend discontinuing it a little bit sooner than when you would imagine delivery to decrease bleeding complications. And EASL also talks a little bit about calcium replacement, which they feel might also decrease the risk of early and late onset preeclampsia. All right, now we're going to turn to the last one, which is acute fatty liver pregnancy. This is thankfully rare. The symptoms are a little nondescript. And remember, in your individuals that are more darkly pigmented, you might miss jaundice, which is very, very common, and only have the complaints of nausea, vomiting, epigastric discomfort, which really don't seem all that unusual in a woman who is pregnant. You know, they often have GERD, they don't feel very well. But if you are having this presentation late in your third trimester, or you recognize that there's associated jaundice, you really have to be very aggressive to make sure you're not going to be sitting on acute fatty liver pregnancy, because this is a rapidly progressive medical emergency. There is, again, significant overlap with preeclampsia and HELP. And so this is felt now to be on the spectrum of preeclampsia, pre-E, which makes it very challenging because you'd love to have clear labels for these. And really, you're not going to have a clear label. You're going to have a spectrum, all of which increase the risk to mother, all of which are usually resulted in delivery. Now, we know with acute fatty liver pregnancy that we have the Swansea criteria, which really reflect mitochondrial dysfunction, and they can help you identify someone with preeclampsia. Unfortunately, they have poor sensitivity for early diagnosis, and they have poor specificity in late disease or severe disease. And so although we do use them, and they're listed here, you want to make sure that if the concern is high and the Swansea criteria are not demonstrating diagnosis, doesn't mean that you're wrong. You might still have a woman with acute fatty liver pregnancy. And then if you watch these women closely, you can see that they have biochemical changes that start to pull in more and more of that mitochondrial dysfunction, including hyperammonemia, increases in lactate and amino acid levels, liver dysfunction, but also complications such as pancreatitis, renal failure, respiratory failure, and then ultimately death. And so this is something that's going to rapidly progress in front of you. Management, like I said, this is an obstructive emergency, and so the most important management is prompt delivery. And this is one where we don't drag our feet. So unlike pre-E or HELP or intrahepatic cholestasis, where we are being a little more permissive with letting the pregnancies go a little bit later, if you think that you have acute fatty liver pregnancy, every second counts, and you're going to go very rapidly towards delivery. We know that the maternal support could also consider plasma exchange. So if you're trying to, maintain that pregnancy for, so that you can do delivery safely, plasma exchange is something that can sometimes help. Maternal mortality is thankfully low. It used to be very, very high, but now with our ICU support, it's low, but fetal mortality is still unfortunately elevated. And although some of our guidelines say that you should do LCHAD deficiency testing, I didn't talk a lot about LCHAD, but LCHAD is felt to be produced by the child and then poorly metabolized by the maternal placental components because of usually in the mother a heterozygote presentation. The child, by the time you get your LCHAD testing for deficiency back, you're already going to know whether that child has LCHAD deficiency because they're going to have been ill. And so some of our guidelines really recommend against testing, and others tell you you should test. I think monitor, and if there are signs of LCHAD deficiency, testing could be important. It's just not going to come back in a time where it's going to be useful until later on. And then there is still the rare need for liver transplantation in those women that do not improve. And so this is still one of the places where transplant is not common, but discussed and considered in women who have coagulopathy and specifically encephalopathy. And thankfully, it does not have clear recurrence patterns like some of our other preeclampsia on the spectrum, but it could recur. And so it's really important to have that discussion before considering or vetoing further pregnancies. So this is just a graphic trying to help figure out who has acute fatty liver pregnancy versus HELP. And although it seems a little bit like a tool that's self-explanatory, a lot of it is going to be the aggressiveness of acute fatty liver pregnancy. You can see here that it has more hepatic manifestations with confusion, and there's going to be a more hypertensive component in those that have preeclampsia HELP on that side. But laboratory features are not always that useful. Early in the disease, having kidney complications lays more towards acute fatty liver pregnancy, although in preeclampsia and HELP, kidney dysfunction is not unusual. And then the hepatic signals tend to be a lot stronger in acute fatty liver pregnancy, but certainly are still present in HELP. And so really it's not, because it is a spectrum disease, it's not necessarily easy or even that important to nicely label these things early. Most of it is going to be very careful monitoring. And if you have a woman who's progressing rapidly, much more aggressive emphasis on delivery. All right, so now we're going to turn to chronic liver diseases that can impact pregnancy. And so it's important to know that these can manifest at any time. You can know them before the woman becomes pregnant, or you can have pregnancy liver diseases that make you evaluate for abnormalities, and then you discover chronic disease or an acute presentation of a chronic disease. Chronic liver disease is increasing in women of childbearing age, and this is important because advanced liver disease is also increasing. So this is looking at just kind of some old data from NHANES, comparing 1988 to 1994 to 2007 to 2012. And you can see that chronic liver disease increased significantly from 10.4 to 25% in that time period. And we certainly know that a chronic liver disease from 2012 to 2024 is much higher. And this was driven by signals in metabolic-associated steatotic liver disease, as well as alcohol-associated liver disease. And it's easy to know that both of those have increased significantly in the US. Maternal mortality, however, remains uncommon, but when you audit the death certificate data, we also see there's an increase in maternal mortality from liver diseases, and it increased in the US up from 2021 to 2018, from 1.25 to almost 9. And so again, not commonly seen, but increasingly more than in the past because of the enrichment in chronic liver disease. We also see higher rates of pregnancy in women with compensated and non-compensated cirrhosis. And again, that's why we started about reproductive health. It's because these women can still become pregnant. And here, this tends to be the majority of the women that have the highest risk for maternal mortality. And most of this is driven by mast cell. And then just a last reminder that fertility is normal in well-compensated cirrhosis, so that you do not forget to discuss in these women of childbearing age the importance of reproductive, preventing pregnancy that's not wanted. So the first thing is hepatitis B. We all recognize that maternal to childhood transmission for hepatitis B is why most people in the world have chronic hepatitis B. And although we used to use e-antigen status as a surrogate, it's really all driven by maternal levels of hepatitis B DNA. And so now our algorithms really emphasize looking at hepatitis B DNA and not so much the e-antigen versus e-antibody status. If your hep B DNA is greater than 10 to the 6, then you want to have a discussion about using an antiviral therapy in that window starting around 28 weeks to prevent maternal to childhood transmission. Although guidelines do say that you can use tenofovir in the form of TDF, lamivudine, or telbivudine, that is changing. And I would say we probably would have a little bit of trouble finding telbivudine since that's not a very commonly used agent anymore. And then it's important to recognize that HBIG and vaccination should be given within 12 hours of birth. And that's usually done very well in the United States. Now, these are the European hepatitis B these are the European reproductive guidelines, where you can see they pull in TAF because there is increasing data now that tenofovir in the form of TAF is safe during pregnancy as well as effective. And so this is reflected in the European guidelines, but not in the US guidelines yet. This is looking at why we would want to consider TDF, as well as some of the maternal outcomes on if you would stop it early versus late. And so let me kind of go back and back up a step. If you are starting an antiviral therapy to purely prevent maternal to childhood transmission and the woman did not need it otherwise, then you're going to want to stop that agent at some point. There is not consensus, but some people would stop at delivery and some people would stop somewhere postpartum, 1 month to 3 to 4 months or someplace out. I personally am a stop at delivery individual. The important part on this is that it doesn't really matter when you stop. Your rates of rebound, a clinical relapse, and requirements for retreatment are exactly the same. They are just going to occur somewhere between 1 to 3 months after you discontinuing the agent. And it's also important to recognize that even if you did not give anything to the mother to prevent maternal to childhood transmission because it wasn't necessary, there is still a risk of clinical relapse or a flare postpartum because of that immune reconstitution. And so, stop when you feel most comfortable with your own discussion with the woman, but you need to monitor for viral rebound and clinical flare because it's going to occur about 1 to 3 months after that decision, regardless of when you decided to do it. So it is not safer to stop early compared to late. So now we're going to turn to hepatitis C. So the United States Preventative Services Task Force, really changed the ability to get hepatitis C testing paid for by giving it a grade B level for really all individuals in the US born that are adults aged 18 to 79. But one of the things in that USPSTF recommendation was to test every woman with each pregnancy. So not just with one pregnancy, with each pregnancy. And you can see that the European as well as the AASLD guidelines also advocate for that. The AASLD guidelines preceded the United States Preventative Services Task Force, but the European guidelines also advocate and feel that this is a cost-effective and important thing to do. So Hep C testing, just like hepatitis B testing, in every pregnant woman, not irrespective of how many pregnancies she has had. That unlike hepatitis B, we are not doing this to predominantly decrease maternal childhood transmission. It is really felt to be more of a recognition and societal impact and not so much on pregnancy-related management. But maternal childhood transmission of hep C can still occur. The overall rate is between 5 and 15%, closer to 5% in hepatitis C monoinfection and greater on that 15% in those that are co-infected with HIV. There is no known intervention to reduce maternal to childhood transmission. So that's an important board question sometimes. We do recommend things like not allowing prolonged rupture of membranes, trying to minimize invasive procedures, but these have not been shown to decrease maternal to childhood transmission. And most importantly, we do not recommend preemptive C-section. But of course, if there's poor progression of labor or a reason for a C-section, you would make those decisions based on the pregnancy. not on the chance of maternal to childhood transmission. Also, there's no reason to discourage breastfeeding, but you want to make sure that you defer breastfeeding if there's cracked and bleeding nipples. Now, AASLD, you can see down here, my little caveat specifically says that there are insufficient safety data on direct-acting antivirals or treatment of hepatitis C to recommend their use in pregnancy as a means of reducing maternal to childhood transmission. So it does not say you cannot treat hepatitis C during pregnancy, but it does say that if you're going to make decisions based purely on maternal to childhood transmission, DAA therapy may not be the first choice. Now, this is the STORK study. So every time you have a statement that says you shouldn't do something, we have evidence that you could probably do this. And so although this has been a little bit slow to recruit, Catherine Chappell has done a great job in treating, in a multi-center study looking at hepatitis treatment during pregnancy and what happens with that. And so this is, again, a little bit messy, but the most important thing is that this did seem to, there were no cases of maternal to childhood transmission. Now, did it prevent maternal to childhood transmission? The numbers are pretty small. When there's only a 5% risk, you may not have enough mother to child pairs, but it certainly did not show any transmission. And more importantly, there was no significant safety signals, and all the women that were able to go through and be tested for virologic cure were cured in the STORK study. And so STORK is using soft valve. We also have other data that looked at soft lidiposphere, sofosbuvir, and a little bit of GP data ex-US that also did not show any safety signal. But we want to make sure that if you are considering DAA treatment during pregnancy, that you're going to use a pan-genotypic therapy. And so lidiposphere, sofosbuvir is usually not first line. So what are our guidelines say about treatment? Like I suggested, AASLD says that there is a lack of recommendation but treatment could be considered, but it should not be done for maternal to childhood transmission, but rather these are in women who might not have an opportunity for treatment postpartum or where this is the most stable time in their lives that you should consider treatment. The European guidelines with slightly different language say essentially the same thing, that if necessary, antiviral therapy with direct-acting antiviral treatment can be used during pregnancy, but with a thorough discussion on potential risk and benefit, meaning that it's not standard, but it can be done if both parties agree. Now, the CDC has changed recommendations on how to test the infant post-delivery. And so this is really, really important. These were released around November of 2023. So our original algorithms said that testing should occur at 18 months with antibody. And if that was positive, that at the age of 3, you should do a PCR. Now we're moving things to a much earlier time point because we all know that even in adults with hepatitis C, in that care cascade, we lost tons of individuals that needed an antibody and then a second blood test for PCR. And so now all of our testing is reflex testing, but the CDC advocates that all infants and children born to pregnant persons with concurrent hepatitis C be tested, and that testing should occur now somewhere between the age of 2 to 6 months to identify children where chronic hepatitis C might develop. Now, there is still a fair amount of spontaneous clearance after that time period, and so they do recommend retesting before treatment. And remember, our first agent that is approved for children, first age is at the age of 3. So both GP as well as soft valve can be used in children, but they are indicated starting at the age of 3. And so you would test again sometime after that first year to make sure that the child was still infected and appropriate for treatment. Also remember, even in your female adults that have older or grown children, because of the near universal screening recommendations, you still want to make sure that they talk to the children about treatment. All right, now this is just an algorithm talking about pregnancy and autoimmune hepatitis. And so first of all, remember that pre-pregnancy and counseling in your patients with autoimmune disease increase the risk of hypertensive complications, preeclampsia. So you want to use aspirin starting before 16 weeks. They should be counseled on the increase also of gestational diabetes, hypertensive complications like we just discussed, preterm birth, and fetal growth restrictions. But women who are going into pregnancy with well-controlled autoimmune disease do quite well. And so fertility rates tend to be excellent, and pregnancy tends to be very well tolerated in women who have autoimmune disease. Your diagnosis in a pregnant woman who is presenting with increased liver enzymes is essentially the same as a person who is not pregnant, although we do not do too many liver biopsies during pregnancy. Still can be done when indicated safely. So pregnancy is not a contraindication to liver biopsy. Immune suppression, again, here, steroids are considered quite safe. We typically will use azathioprine. So there's a little bit of a difference between your women who's coming in with pre-identified autoimmune, as opposed to someone who is newly diagnosed during pregnancy. But if you have a woman who's got well-controlled autoimmune disease, here CellCept or MMF, mycophenolate mofetil, is contraindicated. And we no longer recommend a dose reduction during pregnancy. So although pregnancy tends to be a relatively immune tolerant time, we don't decrease our azathioprine or decrease azathioprine and increase prednisone. You're really going to just continue whatever you had them achieve maintenance on during pregnancy. If you did decide to decrease, though, you're going to want to go back up towards the end of pregnancy, because just like hepatitis B flares in autoimmune disease tend to occur 1 to 3 to 4 months postpartum, because that's when you have that immune reconstitution and higher risk of immune recognition. And although variant syndromes can occur, again, this is pretty uncommon, especially for newly recognized disease in pregnancy. And do not use your alkaline phosphatase late to make huge decisions, because the placental production of alk phos is going to be a little confusing. All right. Now I'll turn towards the end here on metabolic associated steatotic liver disease. This is strongly increasing. So pregnancies impacted by MASLD tripled from 2007 to 2015. And we don't have to be reminded that from 2015 to 2024, MASLD continues to increase in the women of reproductive age. When you look at something, so we get a lot of data from large, well-characterized databases, such as the Universal Canadian Administrative Healthcare data. MASLD was the most common etiology for cirrhosis during pregnancy, which was the explanation in nearly 3/4 of pregnancy. We also know that MASLD increases maternal risk. So just like have already been said multiple times, there is an association with MASLD and preeclampsia, eclampsia, HELP, as well as postpartum hemorrhage, and it increases perinatal risk with preterm birth, both small as well as large for gestational age, and higher rates of NICU stays. Now, this is the NHANES database. So although not, maybe we don't have the same comprehensive data as Canada, we still have lots of good information from NHANES. And this NHANES database looked at using FibroScan in a group of individuals who were at risk for fatty liver disease. And when you looked at FibroScan data overall in the population, the prevalence of NAFLD, so we're calling it NAFLD because the terminology occurred after this publication, but NAFLD was present in the overall population in about 21% of individuals that were between the age of 20 and 34, and in about 1/3 of individuals that were over the age of 40. But if you concentrate on the group of individuals with type 2 diabetes, 70% of individuals, women between the ages of 20 and 40, had fatty liver disease in the group with diabetes. And so that's really important, because if you have a woman who's, who's contemplating pregnancy or who is pregnant and diabetic, the chance that they have concomitant MASLD is quite high. We also know, and this is from Monica Sarkar, that reproductive health characteristics are quite different. So that if you look at this group and here, NAFLD compared to the general population, your NAFLD group is in blue. Just like I already said, low birth weight as well as increased gestational birth weight are both higher. Preterm labor is strikingly higher. Gestational hypertension, strikingly higher. Gestational diabetes, strikingly higher. Repeated miscarriage, so infertility and pregnancy loss, higher, as well as infertility higher. And so although we we can't always use this information in a preventative way, it's really important when you have a woman contemplating pregnancy who has known MASLD, that you can talk to them about some of these risks and what they can do to kind of decrease the risk of MASLD and decrease the risks of pregnancy-related complications. It's also important to point out that PCOS, strongly associated with infertility, but also strongly associated with steatotic liver disease. And here you want to assess pre-pregnancy for fibrosis. Remember, in that Canadian database, women with cirrhosis, 75% of them were from metabolic associated steatotic liver disease. And so although we think that MASLD doesn't really cause cirrhosis until women are older, that is not true. And you want to encourage breastfeeding because breastfeeding has been shown to decrease, it's a good period from many, many levels, but decrease the, postpartum complications as well as risk for MASLD in the infant. So this is, just that same study. So I'll turn just a little bit to cholestatic liver diseases. PBC and PSC have increased, at least probably in their recognition. And we think that most autoimmune diseases have increased a little bit. And here, because of an increase of intrahepatic cholestasis in these individuals, if you have someone who has known PSC or PBC, you're going to monitor their bile acids to make sure that they do not end up with cholestatic liver disease. Now, most PBC is diagnosed after the age of 40, so we have less, women in the reproductive age group with PBC, but PSC can be seen in a younger cohort. Cholestatic liver disease does increase preterm birth as well as reduce live birth rates, but again, these are less common diagnoses. And just like intrahepatic cholestasis, you would use ursodeoxycholic acid during pregnancy, but A-beta-cholic acid is not recommended. So if for some reason you have a PBC patient who requires second-line therapy, this needs to be discussed pre-pregnancy best, because you might not want to go into pregnancy on these newer second-line treatments, and then replace vitamin K in especially those women with more profound cholestasis. So this is just a summary looking at women with more advanced liver disease in pregnancy, as well as women who have risk for pregnancy-related complications. Actually, this is looking at liver masses. So hepatic adenoma are really the mass that we worry the most about. And we have nice algorithms saying that if you have something that's less than 5 centimeters, you can monitor that during pregnancy, generally with ultrasonography with each trimester. But if you have something pre-pregnancy that was 5 centimeters or bigger, you want to address that prior to pregnancy, because there's where you start to see the risks of bleeding and hemorrhage in those adenomas. If you unfortunately did not discover that until the woman was pregnant and it seems to increase in size, you can, certainly embolize those during pregnancy. We do not recommend monitoring things that are at higher risk for bleeding. We prefer to do more preemptive, but if there are bleeding complications, embolization at that time is certainly possible, as well as surgery. Surgery can be done safely prior to the 3rd trimester, preferably in the 2nd trimester, for multiple things, whether it's symptomatic cholelithiasis or an adenoma. Now, hemangiomas and focal nodular hyperplasia do not have the same risk during pregnancy. Pregnancy does not seem to increase size of those 2 lesions, but hemangiomas that are exophytic or significantly large might still have a hemorrhagic risk. And so these are things that are either monitored or addressed prior to pregnancy, preferably, but during pregnancy if necessary. But if you have, most of these women are going to do great. It's really just the exophytic location that's going to be of most concern. And this is just that nice little algorithm talking about adenomas, not hemangiomas or FNH, where it really emphasizes that pre-pregnancy management is best. But if you if you have this recognized during pregnancy, that you want to monitor them closely and you can intervene safely, even though it makes all teams a little bit nervous. And then just kind of a summary slide there. So I'll turn in our last 5 minutes to pregnancy in individuals with cirrhosis. And so this is increasing. And again, the driving factors are fatty liver disease from either alcohol or MASLD. Pregnancy is less common in cirrhosis. However, if you have a well-compensated cirrhotic woman of childbearing age, it does not always impact their fertility. Thankfully, because our maintenance, our medical, our improvements in ICU care and recognition has actually been historically great. So now mortality is quite low. There is still risk, and pregnancy in a cirrhotic woman is nerve-wracking for all parties involved. We can use the MELD score for prognostic information. If it's greater than 10, there is a higher risk of decompensation during pregnancy. So low MELD looks good. But we also know that if there was a history of decompensation, these women also have a higher rate of decompensation during pregnancy. So if you had that woman who had alcoholic hepatitis or and IDs a couple years ago and now is quite healthy, their risk during pregnancy is still higher. And liver-related complications can occur for a while after delivery. And so you want to make sure that you're pretty careful in monitoring for at least a year postpartum. So this is a nice little graphic looking at a study from the Canadian Registry, looking at increasing rates, number one, of childbirth in cirrhosis, and showing that strong etiology of steatotic liver disease from MASLD. Rates of childbirth versus the general population, higher in compensated cirrhosis, but lower in a person who's got decompensated cirrhosis. Makes sense, because decompensated cirrhosis is going to have a higher impact on fertility. But you can see also from this graphic that the perinatal outcomes are actually quite high. Higher rates of intrahepatic cholestasis, higher rates of preeclampsia, higher rates of both large gestational age, large for gestational age, as well as preterm birth, and small for gestational age. So impact on the pregnancy and impact on ICU care. And then you can see that although still uncommon, there is a higher rate of death or need for transplant and decompensation, with the biggest signal being in variceal hemorrhage, although you can see ascites, hepatorenal syndrome, and HE. And just like I already said, that if there's a prior history of decompensation, the risk of decompensation in pregnancy is much higher, whereas if they have always been compensated, the rates are actually quite low. And so it's always ideal to discuss this before pregnancy, but if you have a person who's got well-compensated cirrhosis, no impact on fertility, that pregnancy usually will go through quite safely. Now, it is important to use preventative medicine, right? So what are the biggest complication? Variceal bleeding. And so you want to make sure you've done an upper endoscopy in that woman a year before pregnancy. If you have not, then you're going to do an EGD in the second trimester to understand the risk of variceal bleeding, especially during labor and delivery. And if you see something that looks bad, you can use band ligation or non-selective beta blockers, although that's a little bit more concerning. And just this study is, again, emphasizing the importance of MELD. If your MELD score is low, your woman is going to tend to do very, very well. If the MELD score starts to go up, a greater than 10, then that's where there's going to be most of those complications concentrate. You can also use the ALB or the APR and APRI scores, but MELD is probably used most frequently and has the most data across all of our publications. You can use safely octreotide, antibiotics. So if you have complications during pregnancy, you're going to treat them essentially the same way that you would use, you would treat any woman who isn't pregnant, with the exception that terlipressin is contraindicated still during pregnancy, and probably because it's significant, change in probably what we would worry about, the perfusion of the placenta and the child. Just like all the other statements, we do not do preemptive C-sections. Vaginal delivery is preferred, but you're going to want to make sure you give vitamin K in those women that are more cholestatic or have more advanced disease. And here you're going to have very close observation. So in summary, cirrhosis is an increased risk for intrahepatic cholestasis, preeclampsia, preterm delivery, infections, and mortality and morbidity in both mother and infant. Use aspirin at 16 weeks and in those women at risk for preeclampsia. Still, death and decompensation are quite uncommon. And so although you're going to be scared and you're going to watch this person very carefully, for the most part, they do great. Now, you still do need to not just look for esophageal varices, but remember that these women need to have liver cancer surveillance, but do not use alpha-fetoprotein. Or if you get alpha-fetoprotein, know that it's going to go up because that woman is pregnant. And then this is just a reminder of how to manage portal hypertension in pregnancy. You want to do that endoscopy, preferably prior to conception. But if you did not manage to, then you're going to do it in that second trimester. And consider non-selective beta blockers if the varices are small, and ban ligation if they're large or medium sized. So in conclusion, I want to give enough time for some Q&A. Elevations in ALT, AST, and bilirubin must always be investigated. We worry about pregnancy-induced liver diseases, but a lot of this is going to be just concomitant chronic liver disease in a woman who is pregnant. You want to evaluate your, your patient sitting in front of you using both the pattern of their liver test abnormalities as well as the trimester of their pregnancy. Pregnancy-induced liver diseases are thankfully uncommon, but if you recognize them early, management is much easier, even if management is labor and delivery. Pre-existing liver disease is typically very well tolerated, but remember that adenomas and portal hypertension do carry increased risk, and viral hepatitis should be screened, both B and C now, in each and every pregnancy to prevent maternal and childhood transmission in B and to allow appropriate follow-up management for C. All right. Thank you very much.